Today we shall learn about weaning from mechanical ventilation. Weaning from mechanical ventilation, it is defined as liberation of the patient from mechanical ventilation. It can also be defined as gradual reduction of ventilatory support from a patient who is improving or who is recovering. And weaning success is defined as extubation and absence of ventilatory support for 48 hours following extubation. And weaning failure is defined as any reintubation or death of the patient within 48 hours following extubation. Now we shall learn about few terminologies, that is simple weaning, difficult weaning and prolonged weaning. In simple weaning, you are able to wean the patient in the first attempt. That is, with the first spontaneous breathing trial, you are able to wean the patient and extubate the patient. That is called as simple weaning. In case of difficult weaning, here we need up to 3 spontaneous breathing trials, or as long as 7 days after the first spontaneous breathing trial to achieve successful weaning. That is called as difficult weaning. In case of prolonged weaning, more than 3 spontaneous breathing trials or more than 7 days of weaning after the first spontaneous breathing trial is required. So that is called as prolonged weaning. In this topic, we shall learn about what is the pathophysiology of this ventilator dependence or weaning failure. Why we are not able to wean few patients from mechanical ventilation. So before weaning from the patient from the mechanical ventilation, so the primary pathology for which the patient is intubated and ventilated, it has to be corrected, or the disease process, it should be in the resolution phase. We shall know what are all the factors. First is the respiratory factors, that is the respiratory load, that is increased work of breathing. This increased work of breathing, it may be because of various factors. Patient may be because of the decreased compliance of the lungs due to pulmonary edema or fibrosis or ARDS or pneumonic consolidation. All these lead to decreased compliance of the lungs and increased work of breathing. And also iatrogenic. In iatrogenic, we have got inappropriate ventilator settings. Whenever the triggering is kept inappropriate, that is the pressure triggering is kept, usually we keep it at around -1 to -2 centimeters of water. If we keep pressure triggering at -4, -5 centimeters of water, then patient has to struggle more in order to initiate the respiration. And also the flow triggering, usually we keep at around 1 to 2 liters per minute. When it is kept around more, then the patient has to work more in order to trigger the ventilator. And also myopathies. Whenever the patient is on aminoglycosides or neuromuscular blocking agents and steroids, all these lead to muscle weakness, and these all lead to ventilator dependence and reduced compliance. As I told previously, reduced compliance because of fibrosis or consolidation or ARDS or pulmonary edema, all these lead to reduced compliance. And increased resistive load, that is in a patient with bronchial asthma or acute exacerbation of COPD, there is increased resistance, there is small airway obstruction is there, that also leads to ventilator dependence of patient. And increased dead space ventilation. Whenever this increased dead space ventilation, it is seen in patients with pulmonary thromboembolism, and also because of the ventilator tubings. For example, we attach a catheter mount, that also amounts to the increased dead space. So all these factors. And coming to the cardiac factors. In these cardiac factors, we have got any patient may be having a subtle myocardial dysfunction, and this may be exacerbated whenever you keep the patient on spontaneous ventilation, and this in turn leads to myocardial dysfunction will manifest then, and this leads to pulmonary edema, and again this pulmonary edema, you are unable to wean the patient. So here, whenever you keep the patient from positive pressure ventilation to spontaneous ventilation, there is an increased venous return, and there is also LV afterload also increases, and there is an increase in cardiac output, there is increased myocardial oxygen demand is there. So all these factors, they contribute to they contribute to the myocardial dysfunction. Suppose if there is a subtle myocardial dysfunction, it will be manifested, and also any subclinical ischemia, then it will be manifested. So patient can have this cardiac arrhythmias, or patient can have STT changes and myocardial ischemia, infarction, and pulmonary edema. And also this dynamic hyperinflation, also it also leads to increase in pulmonary vascular resistance, and it also contributes to this ventilator dependence. Now coming to this neuromuscular competence. In case neuromuscular competence, right from the central respiratory drive and the spinal motor neurons, the neuromuscular junction and the muscle, everything, this transmission, it has to be appropriate for the normal neuromuscular competence. Any abnormality in any of this path, it leads to this ventilator dependence. So first coming to this central respiratory drive. So in case of metabolic alkalosis, this metabolic alkalosis, it suppresses the or depresses the central respiratory drive, and because of any sedation and patient having encephalitis and brainstem hemorrhage, all these depress the central respiratory drive. And patient having neuromuscular disease, patient may be having a GB syndrome, or patient may be having some other neuromuscular dystrophies, all this also contribute to ventilator dependence. And critical illness neuromuscular abnormalities. So this will be dealt later in this topic. So it manifests as proximal muscle weakness, and it can last up to weeks to months. And whenever you keep the patient on mechanical ventilation, within a period of some 72 hours to 92 hours, many patients on controlled ventilation within 72 to 96 hours, these patients, they develop muscle atrophy of the diaphragm, and also injury and fiber transformation. And also there is mitochondrial swelling also is seen, and also lipid vacuoles are also seen in the muscle cells. All these are because of the oxidative stress injury. And also other factors for ventilator dependence are neuropsychological. So patient may be depressed, patient may be very much anxious, and also patient may be delirious. All these factors also contribute to ventilator dependence. And sleep deprivation is one more very important factor which contributes to ventilator dependence. That is why we have to give adequate sleep to the patient, adequate rest to the patient is important. We have to give sedation at the night, and we should not try to attempt to weaning during the night time. And psychological ventilator dependence. So a few patients, they may be demotivated, and they feel that I will be well only when I am on ventilator, or they feel that the disease is a progressive disorder and it is irreversible and there is no cure for this disease. So they think psychologically that they are ventilator dependent. And also the metabolic factors. The metabolic factors are like patient hypokalemia, hypomagnesemia, and hypophosphatemia all contribute to this ventilator dependence, muscle weakness and ventilator dependence, and hyperglycemia. And nutrition factors, overnutrition. Overnutrition, it leads to increased CO2 production. Because of this increased CO2 production, again the work of breathing increases. This again leads to increased dependence on the ventilator. And in case of malnutrition patients, there is decreased muscle mass. This decreased muscle mass, it leads to inadequate breath and also ventilator dependence and ventilator induced diaphragmatic dysfunction, and also anemia. In case of anemia, what happens? There is a decreased oxygen delivery to the tissues. Because of this decreased oxygen delivery, what are the compensatory mechanisms? There is increased cardiac output, and also there is increased ventilation. Because of this, you are not able to wean the patient. Now coming to critical illness neuromuscular abnormalities. These are associated with prolonged ICU stay and also multiple organ dysfunction syndrome and steroid use, and also in hyperglycemic patients. They manifest as bilateral and symmetrical proximal muscle weakness, and it is In case of ENMG, you can see it as a sensory motor axonopathy, and sometimes it is difficult to distinguish between nerve and muscle lesion. Okay, and here it takes somewhere around weeks to months to improve this neuromuscular dysfunction. Now coming to ventilator induced diaphragmatic dysfunction and critical illness oxidative stress. Here there is muscle atrophy of the diaphragm and also fiber type transformation is seen. Easy fatigue fibers are there, and there is structural injury of the diaphragmatic muscle, that is there is mitochondrial swelling and also lipid vacuoles are seen. All these are because of the oxidative stress, and this can be prevented to some extent with antioxidants such as vitamin C and vitamin E and also selenium. Now we have got to step 2, that is assessing the readiness to wean. So in case of assessing readiness to wean, whenever the patient's acute disease is in the resolution phase, or the reason for which we have kept the patient on mechanical ventilation, it is improving, then we have to suspect that this patient, we may wean this patient. So that is the suspicion we have to know. The other clinical criteria are: one is the resolution of the acute phase of the disease. Patient should be having adequate cough, and also there should be absence of excess secretions. And what are the objective measurements? In case of objective measurements, we have got cardiac. In case of cardiac, that is heart rate should be less than 140 per minute. Systolic blood pressure should be between 90 to 160 millimeter of mercury with or without inotropic support. So inotropic support, it should be minimal inotropic support. What is this minimal inotropic support? Whenever the requirement of dopamine or dobutamine is less than 5 microgram per kg per minute, or the requirement of noradrenaline and adrenaline is less than 0.05 microgram per kg per minute. And also adequate ventilation. You need a stable neurological patient. Not necessarily patient's GCS should be more than 8. Take for example, patient who is having a severe head injury and his GCS is less than 8. You can still wean the patient provided the patient GCS is not deteriorating over a period of time. So whenever the GCS is stable, you can wean the patient. You can very well wean the patient, but you should not extubate the patient, because there is risk of aspiration is there. So you can wean the patient and keep the patient on TPs, or you can wean the patient and you can do tracheostomy for that patient. Now coming to this respiratory criteria. In case of respiratory criteria, we have got many parameters, objective parameters, that is your vital capacity should be more than 15 ml per kg. Minute ventilation should be less than 10 to 15 liters. This is also very important. Minute ventilation of more than 10 to 15 liters per minute, it indicates the weaning will be a failure. Okay, that means patient's demand, ventilatory demand is more, so you should not wean such patients. And tidal volume is more than 4 to 6 ml per kg, and respiratory rate is less than 35 breaths per minute, and frequency, that is respiratory rate to tidal volume, it is less than 60 to 105 breaths per minute per liter. This is also called as rapid shallow breathing index, that is RSBI. That is, respiratory rate to tidal volume, it should be less than 60 to 105. And also the ventilator pattern should be synchronous and stable, and this P max, that is maximum negative inspiratory pressure, it should be less than -20 to -30 centimeters of water, and P 0.1, that is it should be more than 6 centimeters of water. I will tell you later in this class. And also work of breathing, it should be less than 0.8 joules per liter, and dynamic compliance more than 25 ml per centimeter of water, and static compliance of more than 30 ml per centimeter of water, and this VD to VT ratio, that is dead space tidal volume, and to this tidal volume it should be less than 0.6. And the other criteria or objective criteria are crop index, compliance rate, oxygenation and pressure index. It should be more than 13 ml per breath per minute, and measurement of adequacy of oxygenation. PaO2, it should be more than 60 millimeter of mercury with FiO2 less than 0.4. PEEP should be less than 8 centimeters of water. PaO to FiO2 ratio, it should be more than 250, and we can consider when it is more than 150 millimeter of mercury. And PaO2 to PaO, that is capital A, that is arterial to alveolar partial pressure of oxygen ratio, it is more than 0.47, and alveolar arterial gradient should be less than 350 millimeter of mercury, and shunt fraction is less than 20 to 30%. All these are the objective measurements. Now coming to this crop index. So here we have got 4 factors, that is C is for compliance, R is for rate, O is for oxygenation, and P is for pressure, maximum inspiratory pressure. In case of crop index, it is given as dynamic compliance into maximum inspiratory pressure into PaO2 by P capital AO2, that is arterial to alveolar ratio, whole this divided by respiratory rate. So whenever this crop values are more than 13, it indicates weaning success. Now coming to what are the modes which are used for weaning. SAMV alone, it is not used for weaning, and it prolongs weaning and it causes weaning failure. What are the other modes which are used for weaning are SAMV with pressure support ventilation, and TPs. The newer we have got the closed loop modes, that is adaptive support ventilation, mandatory minute ventilation, volume support, or that is volume support ventilation, and automatic tube compensation. And also non-invasive ventilation. In patients with COPD, whenever whenever that acute phase has been subsided and the patient improvement is there, then we can change over the patient from intubation to, you can change over to non-invasive ventilation. So then it is called as weaning in progress. In this closed loop modes, we have got adaptive support ventilation. There will be a separate lecture, short lecture on adaptive support ventilation. This adaptive support ventilation, it is called as one mode from intubation to extubation. So here we need very few ventilator adjustments, and also it is very easy for the caregiver to manipulate for minimal adjustments to give to the patient, and also there is reduced need for arterial blood gas measurement. And we have got automatic tube compensation during spontaneous breathing trial. So what is this automatic tube compensation? We shall take 2 patients. One patient is having an ET tube, 2 adult patients. One patient is having an ET tube size of 7 mm and another patient who is having an ET tube size of 9 mm. The amount of pressure support which is required to overcome the resistance of the tube is more in patient who is having a ET tube size of 7 mm when compared to the 9 mm. So we cannot keep a same pressure support in both the patients. So that is why this automated tube compensation has come into picture. This automated tube compensation, it is an intelligent mode, it's a closed loop mode. It is kept in such a way that it gives a variable pressure support with variable flow. It is as if the patient is breathing without the endotracheal tube in situ. So this is, in one sentence we can tell about this automatic tube compensation. In this automatic tube compensation, we have to enter the settings or in parameters. We have to enter what is the size of the endotracheal tube, what is, if it is an endotracheal tube or it is a tracheostomy tube. Okay, so all these things we have to enter, and also we have got that is mandatory minute ventilation and volume targeted pressure support ventilation. In group 2 and group 3 patients, that is in case of difficult weaning and prolonged weaning patients, pressure support ventilation and assist control ventilation are preferred. What assessment we have to do during spontaneous breathing trial? we have to do all the clinical assessment and also the objective assessment. During spontaneous breathing trial, how the spontaneous breathing trial it is accomplished? It is accomplished using low level of CPAP, that is 5 centimeters of water, or low level of pressure support, that is 5 to 8 centimeters of water, or automatic tube compensation, or TPs. So in case, what are all the factors we have to assess during spontaneous breathing trial? Means we have to assess clinically how the patient is. What is the comfort of the patient? What is the respirator, that is respiratory criteria? That what is the oxygenation status of the patient? What is the ventilator status of the patient? What is the PaO2, PaO2 by FiO2 ratio? What is it? And okay, so and what is the respiratory rate? What is the how is the respiratory pattern? And also in case of cardiovascular criteria, we have got what is the heart rate and any arrhythmias are there or not, any premature ventricular complexes are there or not, any STT changes, myocardial ischemic changes are there or not, any hypotension or hypertension. All these criteria we have to assess in case in spontaneous breathing trial, and also any axillary muscles of respiration are active or not in the patient. All these things we have to assess. So we have to assess this spontaneous breathing trial for a period of minimum of 30 minutes to maximum of 120 minutes. So if the patient satisfies this 120 minutes, that means you can extubate the patient. And now coming to this P0.1. P0.1, it indicates the measurement of drive to breath. This is measurement of drive to breath. It is indicated by this measurement of airway occlusion pressure. It is also called as P0.1 or P100. What is this 100? This P100 means during the first 100 milliseconds of inspiration, the airway is occluded and the airway pressure is measured. So the normal airway pressure will be during this first 100 milliseconds will be 0 to -2 centimeters of water. Whenever this value it goes below -6 centimeters of water, then it indicates high drive to breathe, and also it indicates weaning failure. So you should not wean the patient whenever this P0.1 or P100 is less than -6 centimeters of water. What are the failure criteria? When do you tell there is failure of spontaneous breathing trial? You find the patient is agitated and anxious, the patient is sweating, axillary muscles of respiration are active, signs of respiratory distress are there, PaO2 FiO2 ratio is less than 150, and PaO2 is less than 60 millimeter of mercury with FiO2 more than 0.5, and PCO2 is more than 50 millimeter of mercury or more, or it increases by more than 8 millimeter of mercury, and pH becomes less than 7.32 or pH drops by more than 0.07 units, and your rapid shallow breathing index, that is respiratory rate to tidal volume, it is more than 105, and respiratory rate is more than 35 breaths per minute, or it increases by more than 50%. Tachycardia, that is heart rate more than 140, increase by more than 20%, and systolic blood pressure more than 180 or more than 20% or less than 90 millimeter of mercury or decrease by more than 20 millimeter of mercury, cardiac arrhythmias, premature ventricular complexes, STT changes, new onset ischemia, all these indicate failure of spontaneous breathing trial. So whenever there is spontaneous breathing trial failure is there, then we have to search for the causes. For what are the causes for this spontaneous breathing trial failure? What are the causes means, as I have told in the previous, the causes for ventilator dependence, same causes, that is the respiratory load, a cardiac load, nutritional factors, metabolic factors, anemia, all these factors. Maintaining ventilation in patient with spontaneous breathing trial failure. Whenever there is spontaneous breathing trial failure, the patient should receive stable and comfortable form of ventilatory support. We should give full ventilatory support to the patient. And Here, what anesthesia and sedation strategies are. You should give sedations at that. It should directed towards early extubation. We have to give sedation during the night time, give adequate amount of sleep and rest during the night time, and in the morning there should be sedation free intervals so that we can assess the consciousness and the mental status of the patient. And now coming to removal of the artificial airway. So patient spontaneous breathing trial is successful. There is no need for mechanical ventilation. Patient with minimal pressure support or on TPs, there is a successful spontaneous breathing trial. Now we have to remove the artificial airway. Before removing the artificial airway, we have to perform this leak test, because in patients with prolonged weaning, what happens is during overinflation of the endotracheal tube cuff, there is mucosal ischemia occurs and there is a narrowing of the trachea. So before extubation, we should know what is the lumen size of the trachea, whether there is leak is there or not. If there is leak is there, then it indicates tracheal lumen is normal. If leak is not there, then it may indicate the collapse of the trachea. So this leak test, so you deflate the endotracheal tube cuff. There should be leak should be heard with a stethoscope, or you can feel leak when you place your hands over the trachea. And when the patient is on ventilator, this leak test, how you can do is you deflate the cuff, the change in tidal volume, or there should be leak of more than 110 ml on cuff deflation. And now this reintubation. So usually the reintubation rates are around 5 to 30%. And whenever the rate is less than 5%, then it indicates physicians are too conservative and they are very much strictly adhering to the spontaneous breathing trial, all this criteria, and physicians are too conservative and they are not taking much risk to extubate the patient. And reintubation rates more than 30% indicate that physicians are too aggressive and they are very liberal with relation to extubation criteria. And with reintubation, there is 8-fold increase in incidence of this nosocomial pneumonia, and also 6 to 12-fold increase in the mortality rate. Now coming to prolonged weaning. The outcome of these patients with prolonged weaning, it depends upon the underlying disease. Usually patients who are having chest wall abnormalities and neuromuscular abnormalities, they are less likely to have a weaning success. So these patients, better they go for a tracheostomy. And also this tracheostomy, these advantages are one is we have got less sedation is required, suction is easier, dead space is less, and also tolerance is less. And this tracheostomy, it has to be done as early as possible, and usually we take a time period of around more than 7 to 14 days after this intubation, and earlier whenever it is required. You think that patient requires prolonged mechanical ventilation, then we have to go for an early tracheostomy. In patients who have got prolonged weaning, they should be referred to specialized weaning units. And also home ventilation is also one of the options to these patients. So this is all about the weaning. Thank you.